he warned me before the injection. He said, "Don't quit your job." And I took his advice.
Don't make any rash decisions while you're feeling
It was just a fact, but I understood now why it works with depression. Because I don't know how to describe it, but it kind of gets you out of this fog that you have. Now, it's got to be done very carefully. I've known of some clinics that they'll come in, here's your injection, and you're out the door within an hour.
Yeah, this guy was very follow up.
Yes, he was very careful about follow up and preparation for the patient.
Hi, welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is my friend, Dr. John Lucio. Welcome to the show, John.
Thanks, Gil. It's nice to be here.
John is the regional chief medical officer of what's called the SSM health system. A lot of people don't know that Sisters of St. Mary's.
Yes, it is. Yes.
And you are a board-certified anesthesiologist and pain management specialist.
Yes, I am.
That's a hell of a combination, John. You were just telling me that pain management used to be closely wrapped and integrated into anesthesia training.
Yes, that's historically how it's been, but now it's expanded to include physiatry, neurology now, psychiatry as well.
Wow, a huge topic.
Oh, it's huge, yeah.
Yeah, it's huge, and you're double board certified. That's pretty amazing. John did his, was it your residency at Michigan State or your medical school?
Medical school in Michigan State.
You did your medical school at Michigan State, and as you can see, I am a Wolverine, a University of Michigan alumnus. And there is some interstate rivalry between Michigan and Michigan State. But when you get out of Michigan, we all love each other because we're all Big Ten, and we want to beat Ohio. We both want to beat Ohio State.
Right.
All right. So we're not gonna. You're not gonna hold that against me.
No, sir. No.
Well, fantastic. Great school. Now, John, you initially did your undergraduate training in engineering and nuclear engineering, and you're in the ROTC program down in Miami, and I guess as a young man, you had visions of being a nuclear engineer, but then you got in a submarine.
Yes, and I'm not a tall guy, but I felt like I was cramped. And I realized that if I was on a submarine for 6 months, and this is the typical float trip for them, I'd probably go crazy.
Oh, it takes a special personality. Astronauts, too. You're in a little tiny capsule. You've got to have a mindset.
Yes, and I have a lot of respect for the submariners that I encountered. Yeah, I really do. They're great people.
Great guy. But it wasn't for you.
No, sir.
So then you told the Navy, gee, maybe I'd like to be a doctor. And they said, you can if you can get into medical school.
Right.
And you got into medical school. And you went to, it was an osteopathic school at the time, and people should realize that DOs and MDs have the same licensures, they're the same board. It really doesn't make that much of a difference in the real world. You are a doctor of medicine. And then you did a residency in anesthesia that included pain management in Bethesda, in the Naval. What was it called? The
National Naval Medical Command.
National Naval Medical Command. Oh, that sounds powerful.
It does.
And then you did some additional training at Harvard up in Mass General.
Yeah.
So you've trained with the absolute best people in the whole world. You've been in naval bases in San Diego. And in 1996, after many years of doing this, we were lucky enough in Missouri to get you here in Jefferson City.
Yes, sir. Yeah.
And you have you were doing anesthesia and cardiac anesthesia and all that stuff and pain management. And at some point, you left doing anesthesia and shifted over to exclusively doing pain management. Is that right?
Yes, sir. About 15 years ago, actually. Yeah. I missed the human interaction piece.
Sure, because when a patient's asleep, anesthesia, you interact before they go to sleep and after they go to sleep, and other than that, it is.
I did miss that part. I realized that. Yeah, so it was like a lifeline for me because it allowed me to branch out, fit my personality better.
Yeah, you're able to do that. Pain is an awful thing. there's some people say it's all in your head, and that there are yogis and people with special psyches who can endure pain, but they're few and far between. I know I'm a total weenie. If I have a total headache, a toothache or a headache, I'm a total wreck. I can't function, and thank goodness it doesn't happen that often. But pain is life altering, and an incredibly important field to work in, isn't it? So you shifted over to pain management and treatment of pain, and you're currently working with, what's the name of the group? Orthopedic and Spine Group?
It's the SSM Spine and Pain Management Clinics.
So they're wrapped together. The title says it all, spine and pain management.
Now, we do see other types of pain conditions there. We see cancer pain. We see people that have catastrophic nerve injuries and motor vehicle accidents. I can't imagine that there's something we don't see there, except for pediatrics because of the age group restriction. But
interesting.
We see people of all kinds,
Now, it's about 6 or 7 years ago. Now, by the way, John is married to Jennifer Sue, a lovely OBGYN doctor who we recently interviewed, who has a podcast coming up shortly. She was a solo practitioner, and she was just burning out. And I can tell you, as a solo practitioner, it's a fine line between working yourself to death and being a good doctor.
Yes.
And she had the realization that she wanted to provide more for her patients, and you or she was interested in integrative medicine, and you and she studied with Andrew Weil in Arizona at their integrative medicine program or fellowship, what you want to call it. It's a 2-year program.
Yep.
And you took that full program, that full fellowship, and you learned the ways of integrative medicine. Integrative medicine means taking, from what Andrew Weil says, taking the best of allopathic and the best of what's called alternative or natural or whatever you want to call it. And if it's evidence-based and maybe not practiced or taught in traditional medical schools, the best of all worlds brought together to give care.
Yeah.
So you did this integrative medicine fellowship, and you've incorporated it into your pain treatment practice. Isn't that right? So tell me a little bit, how did that happen? How did you get interested in it?
Yeah.
And what was the process like of learning this?
Well, I'd been in pain management for many years, and you'll see a lot of terms thrown around. Some physicians will be interventional pain management, and some will kind of define themselves as just overall medical management and pain management. I tended to do everything. I was trained in both and the entire spectrum. And it kind of bothered me a little bit after a while. There was a really significant group of people that no matter what we did, no matter what medication we gave them, no matter what fancy injection we gave them, what technology we used to make them better, there was a group there that really never got any better. And, internally you can feel this, and you see these people come in, you talk to them, and you realize there's some deficits here that I need to fill, but I don't know how to do that because my training trained me to do this. And so after Dr. Sue and I talked about it, we were all, when we think back, we were all kind of converging to that point because Jennifer saw the same thing about the way medicine is now. It's largely driven a lot by pharmaceutical interests, other outside interests, not always favorable to the patient.
Right.
So
maybe favorable to the bottom line.
Right. It is.
Insurance companies getting more and more involved in decisions, what you can do.
And, frankly, interventional pain management has that component, just like every piece of medicine does. So we started learning more about it. And then I realized that when I got into the program, I had another set of tools in my toolkit that I can now use for the patient. So we studied, as you mentioned, all the components of conventional medicine, components of Chinese medicine, Indian medicine, naturopathic, osteopathic, chiropractic. There's a place for all of these and to how we approach a patient. Now, there are some significant obstacles into doing that because it is very time consuming.
Yes.
You have to go in depth into the patient's sleep patterns, diets, functional capacity, physical capacity. Because when you're trained as an interventional pain physician, and you'll see my colleagues probably agree with me, is that you'll do the procedure and then you kind of hope for the best. Patient will typically get better, but it's typically a short-term relief.
Especially if it's one of these nerve blocks or regional blocks. While it's in there,
right. I can make the most severe pain, I can make most people feel better for a short period of time. Now, what happens, how do you address the physiologic things that occur to the patient because they've been in pain for so long is another challenge. And if you don't address that piece, they're going to come back to you. And this is why it's a repetitive industry. And, you know, there's really no cure a lot of times. But that's why it's called pain management versus chronic pain cure, right? So,
sure.
But it was just fascinating. It really opened up my eyes in terms of a whole new world of how to approach a patient that has, you know, just I see a rheumatoid arthritis patient that, you know, they're on all these medications to help with their disease. And then they're coming to me and they've been treated by another physician by, they say, typically after they get through the arthritis medicines and all the things that the rheumatologist prescribes, then they're not getting functionally better. They come and say, what else can we do? And typically their answer is, they've been told, is going to be a narcotic, a pain medication.
Right.
Over time, I've realized that long-term use is just for a very select group of people. Ultimately, and there's a large group that take it and don't get it much better, functionally better.
And end of life, if they have a tolerance or whatnot.
Yes, well, and that's a very hard thing to treat. So I started looking at that, how to approach that, and I have a very prescriptive plan that I use for those group of people, and it usually involves some diet modification. And it's very difficult, as you know, to introduce diets to people because once they hear the term, they'll try it for a while.
Right.
But I can tell you the particular diet that I use, an anti-inflammatory diet. Everybody knows what it was. When we first got out, I introduced it. Patients were like, what is that? You know, and now you give them a handout and they were like, wow. Now it's like it's all over the news. They know what it means.
Right.
But they don't understand it completely and they don't always practice it completely. But in the select few patients that I've been able to really hang on to that diet recommendation, almost 80 to 90% have gotten better.
Wow. Now, I'm going to stop you right there, John. Let's talk about rheumatoid arthritis. The body's attacking itself, typically the joints.
Yes.
They get swollen, they get painful. And with the new biologic medicines, and I'm not a rheumatologist, the goal is to reduce the inflammation. But no one's talking about curing it. They'll just talk about slowing the progression. They'll say, ma'am, this is forever. I can make you a little better. We're just going to slow down the deterioration. Very few people that I've heard of talk about actually reversing it and getting well again.
Yeah.
It was just that the whole plan is just to make it better as long as you can. Right? Am I correct?
Yeah, that's typically the category of disease-modifying medications that are
and they
used.
wouldn't talk about changing anything about their life.
And there's it's right, and there's that theory of the body attacking itself can be applied to a lot of other chronic diseases, diabetes, heart disease. I mean, this chronic stage of inflammation is one of the things we focused on in our program quite a lot. When a patient is in that state, that lowers their pain threshold, and so, like you and I, or average person, could break something. We'd recover in about 2 months, but the person that has this chronic inflammation, that pain continues and that becomes a chronic issue for them.
Or so they're more sensitive, is what you're saying.
More sensitive.
More sensitive to pain.
Yep. And so my job is when I see someone like that or suspecting that, it's not just rheumatoid, but other patients, the fibromyalgia groups tend to fall in that category.
So you see fibromyalgia.
Oh, yes. Yeah.
So here's a hot button topic, John. So do you believe fibromyalgia is a real thing?
I do, but I don't. I have to depend a lot on the American College of Rheumatology to give me definitions because in my practice, I've noticed too many people that came in all with the same looking disease and complaints. So there had to be something there that I just wasn't picking up. Now, since we finished our integrative medicine program, I now start to looking more for chronic diseases that are underlying, such as tick-borne diseases and other undiagnosed rheumatoid.
Tick-borne, like Lyme disease
Lyme
or
disease
something.
is one, and some other ehrlichiosis is another one.
Ehrlichiosis, yes.
We tend to do tick panels now, and a lot of patients that come in.
Oh, you have tick panels.
Oh yeah, you can order those, and oftentimes no one's ever tried or examined that in the patient. They'll come in, they go, well, I've come in, I've had this chronic fatigue, I've got all this body pain, and a normal functioning individual who has been operational in their life or functional in their life suddenly comes in, they're not functional anymore, had this long history now of this chronic pain, they're bouncing doctor to doctor. No one's ever started asking these deep questions. So there's other questions that I ask. I ask for environmental exposures, pesticide, some of the you have veterans that have had previous histories of Agent Orange exposure. We have a new set of veterans now that are coming in that have been exposed to burn pits. Now
in the Middle East.
Right. And now I've got patients that have had, were previously in the Air Force that have been chronically exposed to what's called TCE. It's a chemical that they use as a solvent that's now been removed from the military warehouse supply. But they've realized now it's starting to cause nerve type pain and diabetes and some other airmen. And so I'll often do a screen and I'll start asking them questions about where they grew up, what they're exposed to.
Yes.
And you've got to understand that piece of it. Otherwise, you'll start treating it like a fibromyalgia patient, which is basic symptom control. Now I'll start introducing a lot of times to those fibro patients some of the diet modification, some of the functional changes that they have to do. Sleep is one of the biggest ones. Now, the diet, Mediterranean diet or anti-inflammatory diet are used interchangeably. There's some subtle differences between the two. One, the Mediterranean is Mediterranean. Then you'll have the Okinawan diet, and then the anti-inflammatory kind of put those components together. It's not complicated, but
tell me about it, please.
Basically, the Okinawan diet was basically seafood-based and most of the traditional Asian foods. And then the Mediterranean diet was Mediterranean, a lot of olive oil. A lot. And I'm talking about you buy the bottle at the store, you're drinking half of that
ounces.
a week. Yeah.
Ounces.
I can't do that. But
right.
And so they combined the two together. And the reason they use these is because they looked at those particular populations and they call them, blue zones, if you've heard of those before. These are individuals that live a long time, have very vibrant lifestyles, still having sex in their 80s, still working.
Right.
And they're going, what is different about these people? Now, the diet alone wasn't the one thing. Of course, social interaction was the other. And they looked at the diet and came up with this anti-inflammatory diet, which, by the way, in my clinic, I have a handout to start people out.
Good.
And but that doesn't work by itself. Okay, so if you look at the studies behind the Mediterranean diet, it works better with people who have proper sleep. So to say, I'll never give one person and say, this is the one thing that's going to help you.
Right.
Okay, you've got to do these three other things, three or four other things.
Totality. It's not an individual
thing. Now,
thing.
why it's hard, because patients nowadays, they come in, they want this cause and effect relationship, right? You give the pill, hey, I feel a whole lot better within an hour. It's hard to compete with that when you're talking about something. By the way, I'm going to give you something that's going to take 2 months to feel better. And I'm going to give you an example of this. We use peptide therapy, and I recommend some of it. I don't know if Dr. Sue discussed any of that.
No, she didn't.
Have you heard of the Wolverine peptide? It's called BPC 157. So
Tell me more.
Okay, it's used a lot now by the NFL and trainers. Before, they used to do a lot of regenerative medicine, injection of PRP and bone marrow, stem cell, and they've kind of gotten away a little bit from that, and they're starting to go more towards peptide therapy. Peptides typically are prohormones, okay?
A peptide, by the way, is a small piece of protein.
Okay, exactly.
About 40 amino acids or less.
I've been surprised how many patients know what I'm talking about when I bring it up.
Yeah, they got it internet. They Googled it.
It is, and they understand what it means. But, a lot of the medications that are used in diabetes now, the weight loss ones that they're used, that was a peptide. A smart pharmacy company decided to change a couple of molecules on it. Now it's branded under their name. That was a peptide. If you look it up.
Sure.
So In musculoskeletal, in the area of musculoskeletal medicine, BPC 157 is what they call a Wolverine peptide.
Where do they get the word Wolverine? Was it designed in Michigan, or is it from a Wolverine?
That's a good point. It's actually been used for a lot of soft tissue injuries and tendinopathies and tendon injuries that have gone out. And actually, Jennifer and I, when we started learning about this, I tried it on myself. So,
Best place to start.
I'm not a spring chicken, and I had this chronic, really bad Achilles tendonitis, and I like to run and exercise every day. And,
by the way, you got some guns under there. I wasn't shaking your arm. You got strong muscles, John. Very impressive.
Well, thank you. So I took it, and I thought it wasn't going to work. After about the second month.
What do you mean take it? You injected it into your Achilles?
Sub-Q. No.
All right, so it's a systemic. You put it under the skin. I just put it under my skin. I injected it under my skin. This Wolverine peptide.
It's called a Wolverine peptide. The name of it is BPC, B as in boy, BPC 157. So I did it for 2 months, and all of a sudden, 2 months, it's like I woke up, it's like I'm jumping rope again. And I don't have that nagging pain. I didn't have to take the anti-inflammatories, which is typically recommended. I tend to, in fact, to be honest with you, now that I mentioned that, I rarely ever keep any of my patients long-term on what's called non-steroidal anti-inflammatory anymore.
Okay.
I have some alternatives through my integrative medicine program that I recommend. So anyways, that's peptide therapy in a nutshell.
But what does that peptide supposedly do?
Well, it supposedly helps stimulate other changes in our molecular healing process that accelerates it.
Accelerates healing.
Right.
Okay.
Just like the
now inflammation accelerates healing when it's focused and when it's controlled, right?
Exactly.
How come I've never heard about this Wolverine peptide? Does it have a name? Does it have
BPC 157?
But it's not going to be. I'm not going to see it on TV with some fancy ads.
You have to go through a pharmacy to online pharmacies usually sell it. We have a way, Jennifer's figured out a way to order it directly for her patients. It's getting harder to get these, and I'll tell you why. The pharmaceutical industry has been pressuring the FDA to restrict distribution of these medications.
Okay.
Simply because it hits their bottom line. They are now in development of drugs that look like these and going to call it their own.
That are going to be name branded with the fancy ads.
Yeah.
Okay.
Yeah. And so anyways, that's part of it as well. So, and I can give you another example even where I had to take, and I mentioned NSAIDs because
NSAIDs are like ibuprofen. Yeah, in fact, aspirin's an NSAID.
Yeah.
Aleve, naproxen, and a bunch of those COX-2 inhibitors, some of which were taken off the market.
Yep.
All NSAIDs.
If you look at the FDA, they have a black box warning for NSAIDs, and they've had distributed it twice already. And they increase the risk of heart attacks and strokes. So you have an individual, male, who's hypertensive, has a risk, coronary artery risk that's elevated based on genetics and so on, and they've already been told by the cardiologist or their family practice, we got to really watch your cholesterol. They shouldn't be taking these long term. So I came up with
by the way, I always got to put in this plug. Cholesterol is a very small piece of the picture. High sugar, high blood pressure, chronic inflammation, much more damaging than cholesterol. And I'm going to have some experts on to clarify this in future episodes. Okay, I just want to go on.
I totally agree with you on that, too.
Yeah. Small part of the picture.
So part of the alternatives I get my patients, and I recommend, is a medication it's a supplement called SAMe.
So I've heard of SAMe.
Yeah, and I've been using it for years. And when we finished our program in Jefferson City, I was recommending it so much that my patients were spreading the word out. And there was a local shortage of it.
They ran out.
But it's actually one of the interesting side effects to it is it's a mood elevator. So one of you have a chronic patient who's depressed because of the pain, comes in, they need you need an anti-inflammatory, and I give them as an alternative. Now there's some contraindications. You can't take it if you have manic depression, because that can accelerate it or exacerbate it during the manic phase. So I got to be very careful. And so I usually do a quick screening of the patient, see if they have any kidney, liver, any end-stage issues going on.
All right, so don't go out and buy SAMe until you've been evaluated for appropriateness.
Right. Now, a lot of physicians don't know what it is, and you can Google it really quick. And when the studies show that if you look at SAMe, you compare it to over-the-counter, Aleve, or ibuprofen, they're very similar results.
Okay.
Now, SAMe takes a little while to get there, get to the end game, versus ibuprofen. You take it, you'll feel better within 1 to 2 months or 1 to 2 hours, right? So that's the hard part of my job is trying to talk patients into it. And then we started putting on patients that also using turmeric.
Turmeric, sure.
Everybody knows that now, right?
That's
everybody's taking it.
Vedic way back,
Yes, so
thousands of years old.
We got that piece from our Indian medicine study. So not many people know this, but I have tons of my patients that will come and I'll see that as a supplement that they're taking. I said, tell me how you take it. I've been taking it, don't feel any better. Usually they're underdosed. And I usually works better with ginger root.
Okay.
Now you're using about 1,000 milligrams a day. The trick with turmeric, though, people don't understand is that you have to take it with black pepper. If you don't take it with black pepper, it's going to go through the upper GI, and it's going to be digested and way down the line and maybe get excreted. You won't get the active ingredient of it. Black pepper, right, allows it to be absorbed like you need it to be, so it gets to the rest of the body. And they come in pills now. Now that over the last 2 years, I go on Amazon, there's a black pepper and turmeric preparation.
In one pill?
Yeah, one pill.
Already prepared?
Yeah, already there. Yeah, and they combine it with ginger root, which is fantastic. So people have gotten used to this, but I can't believe how many people come in just taking the turmeric. And I said, well, how does it work? Well, not really. I can't understand that because you're not absorbing it like it needs to be.
It's not what you eat, John. It's what you absorb.
That's part of it, yes.
Yeah.
So, anyway, so I spend a lot of time talking to him about these other pieces of it. And then I'm giving you another example too. Part of my background, so being as an anesthesiologist and integrative medicine, your reading starts to expand, right?
Yes.
So you're not just sticking to your specialty anymore. And so I've had a couple of my patients that came in with something called chronic regional pain syndrome. Or it used to be called RSD. It hasn't been called RSD in 25 years, but people still use that term. It's a terrible disease. The way to think about it as if you get hit with a hammer, that's a bad message.
Right.
Okay? Boom. You get hit, you're hurt.
Right.
Chronic regional pain syndrome is actually a bad messenger. Something gets miswired in your brain that you continue to think you've got the pain there, and your body reacts to it, and it ends up with devastating issues.
And it's a horrible reaction. This isn't in your head. It's like, for example, let's give an example. You get some kind of limb injury, and it can be almost any sort, I think. Yeah. And it heals up, and it gets better. Mm-hmm. But you can get this reflex or whatever you want to. Maybe you could help me with this. Where the limb gets redder and hotter and more painful, and it's just horrible.
The present theory now, why that occurs, is because there's a different mapping goes on in the brain now. It resets itself to think that down here there is an injury. The way the body responds to it, it acts like it's inflamed. It sends all these mediators to help trying to heal.
Yeah, so it's not pain going to the brain only. It's from the brain going back out.
Exactly. Brain is now convinced there's an ongoing injury there. So there's a couple therapies we use. We use interventional pain management to cut off that signal, and we put patients in therapy, which is very, very, very important. And there's medications, a whole host of them that are being used now.
Explain what that is. So it's not like a local block or anything like that?
Typically what you want to do is it's typically for the upper limb is what's called remember it's sympathetically mediated, right? So it's a sympathetic part of the body that's activated. It's this fight or flight part of the body that's activated. You have to shut that part of it off. You can't just shut the nerve. Although some people have done that. But like say for the upper limb, we do what is called a stellate ganglion block. Okay, it's right here in the neck. Yeah. Okay, it's a lot of high-priced real estate there. Yeah. So it's got to be done, and with diagnostic help, in my opinion. I was taught to do it blind because at the military, you were in the field sometimes, or didn't have all the resources you need. And then for the lower body, it's the same thing. There's a celiac plexus, a sympathetic plexus that's down below in the lower spine that you can block. That blocks that sympathetic outflow to the legs.
Are you coming this way?
Yep. So you do that, then you got to put the patient in therapy. Then there's some medications you can add. Typically, there are a lot of antidepressants fall into that category to get that patient back up. The goal is to get them out of that pain state and get them functionally better.
When you say therapy, what do you mean by that, please?
Physical therapy. Yeah, because one of the most interesting things about that particular disease, there's something called mirror box therapy. So the patient is looking at their arm and they go, wow, it's causing me pain, right? So you do put a mirror that looks like the left arm is moving, but it's really the right. You set up the mirror, and so suddenly they're saying that my left arm now is better.
I've heard about this.
It's just
rewiring a mirror box.
Mirror box therapy.
And the brain attributes the good limb. And it repastes it
Isn't that interesting?
Kind of cuts and pastes it onto the bad limb.
I don't know how that works. God maybe is involved in it. I don't know how it works, but
I've heard about this.
Yeah, and the ones that don't seem to respond as well are the ones that are skeptical, super intelligent.
You have to buy
into it, and so it's just fascinating, that whole field. But I've had patients that have been through that process, and now they come to me and look, I've had this for 8 years. Now what do I do? They've got this limb. They can barely shake a hand. They can't get dressed.
Oh, so whole life is changed.
When that started, I had previously been doing some studying about ketamine infusion. So I found a location in St. Louis that do a great job. And I've had sent them 2 patients recalcitrant. They were just at their wits' end. Couldn't get any better.
Right.
Almost 80% better on both cases.
I was like shocked. IV ketamine?
Intravenous.
Super low dose?
Yeah, it's typically low dose. In fact, Jennifer and I, Dr. Sue and I, went to Tampa to watch a practitioner who's got a very busy practice, and we had it done ourselves. It's fascinating.
Did you feel very sedated or dissociated?
Nope, I didn't. It is the most, it was the most uplifting experience I've ever had. And
well, I'm hearing great things about it. They're finally doing research on it.
Exactly. Now, it doesn't work with everybody. The gentleman does a selection. He does a screening, and we went up there just specifically to see how his practice was run. And afterwards, I spent the whole time on the plane writing idea after idea after idea. I just couldn't stop.
Yeah.
It was just fascinating. But anyways.
Have you ever been in a flotation tank?
No.
If you ever go in a flotation tank where you're sensory deprived, make sure you have a voice-activated microphone. That would be the best. Or paper, because you will have ideas. After a couple hours in there, your brain, you're going to have all these. I remember I did, and I had all these ideas.
Who
and
does
I ran
that
out.
Around here?
They're around.
Okay.
They're around. You're going to get ideas. The world's like, I think good in the shower. Well, you think you could go in the shower. It's 100 times better there. Make sure you write, you have paper, or you have a thing you can write down your ideas. But so anyway, here you're on the airplane. You're having a brainstorm.
So it just went on. Now, he warned me before the injection. He said, don't quit your job. Because I was convinced I had like 2 or 3 pretty good ideas about a business I wanted to start. And I took his advice.
Don't make any rash decisions while you're feeling
It was just a fact, but I understood now why it works with depression. Because I don't know how to describe it, but it kind of gets you out of this fog that you have. Now, it's got to be done very carefully. I've known of some clinics that they'll come in, here's your injection, and you're out the door within an hour.
Yeah,
this guy was very
follow up.
Yes, he was very careful about follow up and preparation for the patient. That's the only problem I have with a lot of these quote unquote IV clinics that are out there. You really got to prepare the patient. You really do. You have to prepare the setting, prepare the expectation, and understand what you're treating. Depression is one of those that's now being used with ketamine. They have the nasal ketamine now that's out. It's available. So anyways, having the training that I did allowed me to broaden my perspective a little bit. And plus my anesthesia practice, understood how to use, because I used it a lot.
Sure.
It's called, to me, it's the best battlefield anesthesia you could have, because it doesn't depress the breathing. And if you're bleeding, it increases your heart rate and you maintain your blood pressure. But I never use it in those sub-anesthetic doses like they do, and over a period of time. I was so impressed with the outcome that we tried to put it into our clinics that we have here in Jeff City. It was just very difficult because you have to have, insurance doesn't cover it.
Right.
You have to have a cash-based practice. You have to have very tight process in terms of monitoring and dosing and making sure you follow the patient, make sure that the correct dosing. Now, there's a risk there. I've had one patient that I've seen that came from outside that, as a patient, had ketamine at another clinic outside the state, and they were giving almost anesthetic doses. And this person was desperate for another ketamine hit, is the way I can describe it. My opinion was that patient is psychologically dependent now. They were addicted to it. It went beyond the therapeutic piece of it, and now they're addicted to ketamine, which is possible. Yeah.
It's possible. It's a different type of addiction.
Yeah.
And even with propofol, we know Michael Jackson needed higher and higher doses to sleep.
Yeah.
You don't get a buzz from propofol, but you get that sleep.
Yeah, you get a restful 8 minutes.
And there is a habit of sorts created.
Yeah, yeah. So, anyways, that's what got me into start thinking more beyond what we're doing. As an interventional pain physician, as just playing the medications we have. Honestly, in the last maybe 10 years, there's very few really super effective pain medications that are on the market. If you look at narcotics are the best. I mean, if you and I break a leg, I can tell you we're going to be asking for narcotics. It's just the only thing we have on the market.
You got that thing, you're rubbing, you put that morphine right through your pants.
Right.
Just get it in there. You've been shot, you need something.
There's nothing that we replace now that affects that particular receptor in the brain that gives you that pain. Now, you can talk about hypnosis as a way pre-op, but there's no way I would want to have any significant surgery without the anesthesiologist giving me narcotics, period.
Yeah, and I've heard with the people have surgery with hypnosis, they're just they still feel it. They're in a place where they just grin and bear it, but they're still feeling it. It's not that it doesn't hurt.
I don't know how they do that. I really don't.
Deep hypnosis, but apparently it's very few people can do it.
Yeah, you have to have a really good practitioner who knows how to do it. So, but anyways, it's...
So ketamine has potential for chronic pain. So this regional pain syndrome, you're getting better. Can I safely say you're getting better results nowadays than you used to?
With I have more tools now, right? So I can go beyond that part. It is very hard. A lot of people in our culture to tell somebody, you need to start meditating, right? So that's part of. If you got a receptive person who understands how it works and how to do it correctly, then it typically works well. In our environment, our market, we don't have too many. We can give them some rudimentary training a little bit, but in a private practice, you got 15 minutes, right, with the patient, and
unfortunately, that's 15 minutes might be a long visit.
Yes, exactly. And honestly, the patients that come to me, they are in serious pain.
Oh, man.
I can go on and on about this other stuff we've just discussed, but they go, just do something about this right now.
Help me, please.
Right, and that's where the interventional part kicks in. So I can do that piece, get them under control, see them again, and then I'll start, when they're a little bit better control, I can start asking questions.
Go over the acute phase.
Yeah, and I just ask them a question about their diet, activity, sleep, mood. Right now in our pain clinic, we do depression screenings now, which we didn't always do. And that plays you'd be surprised, or I was surprised anyway, the high scores of people I thought had it together. We live in this society where we don't divulge much. There's a lot of underlying anxiety and depression. So when you throw pain on top of it, it's just misery for a lot of patients. So once we identified patients that have that high depression score, we immediately have a referral system to see a psychiatrist or a mental health worker.
And can your usual, very common antidepressants, such as these SSRIs, the Prozacs, the Zolofts, the Celexas, I could go on and on, do those have a role here?
They do. In fact, we use them very frequently. Almost, you'll see Cymbalta is one of those used very frequently, and Lyrica. Those are two. Actually, Lyrica is not an antidepressant, but the Cymbalta has been good evidence that it helps with some patients with fibromyalgia and their depression on top of it. Almost all my patients that come in, everybody knows this now. Most of fibro patients know which drugs work, And so they're already they've come in, their family doctor's already prescribed it, and now they're still not any better. What I've learned, though, don't stick a needle in everything. So
I love it. John's rule of thumb.
Yeah, because
don't stick a needle in everything.
It is so easy with fibromyalgia patients to find their area, because they'll just point to it. Oh, this pain is killing me here. And it's so tempting to just put a needle, inject a local anesthetic, and hope it works. Oftentimes, you're not really getting the area where they're. I mean, it's such diffuse overall pain. You're not. You could give them toxic levels of local anesthetics and still not get to the relief they need. So you really have to dig a little bit. So.
God, and don't dig with a needle.
Yeah.
Now, you were in a spine surgery group and you deal with spine pain. What types of spine pain are there, and what can you do about it?
Well, you can. It's a spectrum. Honestly, by the time age of 30, if you and I get an MRI in our age group, everybody in this town, I can guarantee you 70-80% is going to show some level of degree of arthritis, some level of disc herniations, or something compressing on a nerve.
The spine tends to degenerate over time.
Exactly, it does. And I was surprised how many terrible-looking spines with people with very little pain. And that is pain that I think we should have more.
Sure.
Or people that had severe pain. The MRIs don't show everything. Now, there's a limitation.
Yeah.
I'm going to tell you about this. The MRI is a static film, right? So you're sitting still.
Yeah, it's not dynamic.
Not moving.
You're
Exactly.
Not moving.
So nobody knows we don't have the technology yet to do that. We infer things, right, from the MRI, and we make a decision on surgery or no surgery based on physical symptoms as well. So typically it's arthritis. It advances. We get it after the age of 30. In fact, if we survive cancer and heart disease, we're going to need a new spine of some kind by the age, as we get older. That's the next thing to go, joints as well. So there's different ways to go after that. Now, if someone has severe compressive pathology, in other words, something's really pushing on a nerve and they are in severe pain, they probably need surgery. I mean, that's where the spine surgeons come in. We're usually before that point.
Okay.
And people have some things that just need a little bit of help getting over with, a nerve block of some kind or a steroid injection. We can do those things. Now, you've had a subset of patients that have been through 1 to 3 surgeries now.
Oh.
And now those are the hardest ones to treat. They come into my office. Their MRI looks okay. It looks like they've had surgery. Structurally, they fixed it, right?
It was a good nothing went wrong with the surgery that you can tell.
Yeah.
But now you've got scar, and they're still miserable.
Right. So
they're not happy campers at this point.
Yep. And that's a different group of people to treat. We use technologies such as intrathecal pain pumps, which usually deliver morphine. We use something called a spinal cord stimulator, which is basically 2 leads that we put into the spinal canal in the epidural space that actually stimulates the inhibitory pain fibers to the brain.
Do you do that procedure?
Yep.
You put in
one of the busiest, yeah.
Oh, yeah.
So, but it's a very selected group. And typically, I make sure that the patients have what's called a 7-day trial, a very solid 7-day trial, where they've got to be coming in, clicking their heels, saying this is the best thing they ever had.
I mean, is there there's a temporary?
Yes, there is a temporary lead we put in. We tape it in. It's got to go for 7 days. Now, there's debate about what % improvement that patients have to have. There's a group of individuals or thought that say 50% is okay. Now, 50% to me, when you think of placebo, 30%,
sure,
you're only talking about an additional 20%.
It's a marginal improvement.
To me, in my mind, that's my personal opinion. My patients, I insist on at least 70% improvement.
Sure.
And I make them go through a functional evaluation with physical therapy during that trial week. So by the time they get to me, I've got 2 data points. I've got the pain one, which is very subjective. Then I've got the functional one. I've got the physical therapist now telling me, okay, the range of motion measured before with stimulator off, stimulator on, shows improvement. And so now I've got in my mind, I've got a whole picture here that I can think this patient is going to do well.
Now you have a good prognosis candidate.
Yes, exactly. Honestly, in my practice, from the time I used to do this to the time I've developed it now, I always tell my patients, think of this as in 5 years, you want me to take it out. Because I want you to you've got to do two. I make them promise. There's nothing.
Sure, there's nothing wrong with it.
Right.
I tell my patients too. I say, look, this is a two-way street. We have to work together. For a lot of problems, there is not a magic pill. It is a team. True. It is a group effort.
Yep.
So continue.
So they've got to lose weight. They got to promise to lose weight. They've got to promise to stop smoking. They've got to promise to exercise and really participate in a physical therapy program. So after they agree to that, then we'll do the trial. Everything works great. I'll put the implant in. I'll see them after they've healed, of course. I've seen them 2 months later. Like, now we're going to start your physical therapy.
So this implant, is there like a central thing here in the belly?
It's all Bluetooth now.
It's all Bluetooth.
Yeah.
So there's a control thing. Is it is it in the belly?
Under the skin, yeah. And
we're up here?
Usually in the back.
In the back. So there's a device in there, and you can communicate it Bluetooth.
Yep.
Love it.
Yeah, it is. It is fantastic.
Do the ear pods get in the way?
Who knows what's next with them? The companies are very competitive against each other. It seems like every few months they got to come out with another innovative component to it.
Sure.
So after 2 months, they got to go through the physical therapy. And I start watching their weight. And I say, look, I'm going to put you on the anti-inflammatory diet. I don't care how you get there, but you're going to have I try to be as conservative as possible. Let's just plan on 2 to 4 pounds a month. Okay.
Yeah,
you can
something
show me
attainable.
Yeah, something that's positive direction.
And are you using many of these GLP-1s, the Mounjaros?
No, I don't get into that because I let the family doctors do that. There are some side effects to those.
Oh, yeah, there are.
I let them handle that part, and I don't care how they get there.
You wouldn't object to it. Okay,
no,
but if they can fairly safely get consistent, persistent weight loss going in the right direction, that's what you're looking for.
And the one thing I tell them, I said, if you don't do those things, if you just depend on this device to be the thing that saves you, within 2 years, this is not going to work anymore.
And that's a great motivator. Yeah. You don't have to say you're fired.
No,
the pain's going to motivate them.
I try to extend more grace in that to the patients.
But
typically I let them know the reality of it. And none of these things we do, and a lot of what interventional pain management do, if you look at the studies with them, they were never meant to be a standalone therapy. Okay. Now,
what wasn't the
epidural injections, the steroid injections? None of these are never ever was I trained to think that this is a standalone therapy. A lot of people think that it is because people say, "Oh, this shot didn't work." I said, "Well, what else did you do?"
Nothing.
Nothing.
Right.
So it's like, well, you really need to do these other things. Now that I've given you this window of opportunity now, you're feeling better. You need to start doing the exercise that make you better. Start doing whatever lifestyle changes you need.
Right.
And so that's part of the discussion. Like you're right. It is a back and forth discussion with the patients. And, if you get a motivated patient, it works fabulously. If a patient that doesn't have the skills, doesn't believe you, or just wants the shot, and they want a shot 4 times a year, and that's all they want me to talk about. So, you've got that group. I got to meet them where they're at.
And your side of the street is clean, John. If you told them about it, and that's what they want, that's all you can do in life is keep your side of the street clean, do your best, and they're going to accept what they can, what they will, and that's all you can do. Yeah, pain is a great motivator. Also, infertility is a great motivator.
I bet it is.
I have people come in, they're desperate for a kid. I tell them what they need to do, and most will, in fact, dig deep and do it.
Yeah. In fact, I did when I was reviewing the Mediterranean diet. I think there was an improvement in reproductive health, I think, when they used it.
I'm sure.
I can't remember the study. Of course, I didn't. It's something I feel, but about 6 months ago, I was very impressed with it. I go, wow, this is fascinating.
Healthy people are more fertile. I don't think anyone would disagree with that.
No, it's true.
Yeah.
It's true.
So you do a lot of work with spine pain. You've got spine surgeons. You've got a great team. Clearly, you have physical therapists, and you're the pain manager and these great surgeons. Multidisciplinary is called. And you need that whole team of talent, don't you?
You do. And I'll tell you, it's very, very, very difficult in this insurance environment.
Don't get me started on insurance executives. Oh my God! When they announce their bonuses, their tens of millions of dollar bonuses.
Yeah, and I see it acutely on my other job, since I'm in charge of all the clinical quality in that hospital and the clinics. I'm in also charge of the understanding how to address the denials that we have in care. And so it is, I think if the general population really understood what is happening now, they would be mortified, and they put more pressure, I think, on their elected.
And when I have to call, it's called a peer-to-peer. When they refuse to, and I get a peer, and the person I'm talking to is just barely speaks English, let alone not you know,
and doesn't know your field.
It doesn't know my field very well.
Yeah.
I had one doctor say, well, I had to do this huge surgery and open someone up, take all these tumors out. And they were insisting she could go home right away after it. It's like, I wouldn't send my dog home right away.
This is a daily fight.
And they said, that's a topic for another day.
Yeah. I'd love to talk to you about that one, but it's just, you're right. And, but, you know, I think the bottom line is people just have to be a lot more proactive and understand when the physician's trying to introduce these other pieces, you know, make sure you go to somebody who can offer these other things. If they go to someone like a pain physician that says, okay, I'm going to give you this shot. He's like, well, what else? What else am I? Well, I'm just going to give you another shot when the pain comes back. Well, then what else? It's like, another shot we'll give you.
And you had 7 minutes. So if someone needs to see you, and they need a full hour, they need a long time to talk to you. These fall outside of the guardrails of insurance, don't they?
Now they do. Now, what I'm going to be doing, it's hard for me to do this now in my present practice. Now, I've had the privilege to working sometimes in Dr. Sue's office. I've got a few private patients that just come to me just for that. They've already been through all the chronic pain physicians and other clinics. And so they want me to help them coordinate their pain care.
Sure.
In my clinic at St. Mary's, I do see individuals. I cannot give them an hour. It is impossible.
No, you can't.
I can see them as a new consult, but I do see patients that come in that already say up front, look, I don't want any narcotics. I just want to talk to Dr. Lucio to help me explain what other options I have with this particular pain problem. I've already been to these other clinics because oftentimes I have a PA that I've trained, understands the red flags of patients we cannot deal with. We don't have the resources.
Sure.
Most of them are mental health issues and so on. To get past that filter, if they say the magic words like, I know Dr. Lucio has been doing integrative pain management, I just want to talk to him as a new consult. I've already seen, and here are my records. I'd love for him to review them. And I can see those individuals. So,
yeah. We can't help everybody.
I know.
I have an occasional patient who wants to get pregnant and they have no eggs, they have no tubes, they have no uterus, they have no male partner, you know.
Yeah.
And I have to say, look, I can't help you.
Yeah.
I just can't help you.
Yeah.
And we can only do what we can. Like I say, biology is very cruel.
Yeah.
You know, it doesn't care what I think.
It's agnostic. Yeah.
It's agnostic. Yeah. Well said.
Yeah.
Well said. So you also deal with cancer pain.
Mm-hmm.
I understand bone pain. Some of these cancers attack bone. Are they breast and prostate, for example, go to bone and bone? You just touch a bone. You kick yourself and get kicked in the shin. That's bone pain. It is
the most deep, aching, gnawing pain I've ever had to treat a patient for.
So what can you do with cancer pain other than just flood them with high-dose narcotics, which I assume has been the treatment for centuries? There
is, and of course there's ways that oncologists use, and I work with them, is to shrink the cancer as much as possible. Then we will we'll try some nerve blocks. There are some different types of blocks that I do, like, for example, pancreatic cancer. There's something called a celiac plexus block that I do, and I can actually obliterate that celiac plexus. It's usually people have end of life and their pain is so bad.
Yeah, pancreas kills you quickly, frequently.
And it is very, very painful. And those are individuals I do a special type of block for, and there's a neurolytic agent, chemical agent that I will inject. I'll actually just burn.
Is it alcohol?
It's phenol typically.
Phenol, that's a cyclic alcohol. Yeah, it's what's in gargles and whatnot, chloroseptic. Yeah,
and you can still use alcohol too, but typically that'll be the one that. And then some people will do they'll burn it. They'll burn. I don't do that in my practice.
Now, is that done under anesthesia? Is it through the belly?
It's through the back. You can access it through the back. Yeah,
that way you're not going through the bowel. Okay.
right? Now there's an approach to do that through the front, but I was not trained in that approach. They're usually done with patients just under, monitored anesthesia care, where they're like a twilight.
They're asleep, but they're still breathing on their own.
Yeah. So that's always possible. So that's one area. And then there's also other medications that we can use. Now, if you understand the physiology of the brain and how pain, the multiple receptors of the brain, everybody always thinks like they always focus on the narcotic one, which is the mu receptor.
Okay.
There's kappa, there's delta as well. Now, if you start thinking of the different drug classes you can use to address those, then you can kind of create, lack of a better word, a cocktail for them. I mean, we're using it for this, and you got to go stepwise in terms of getting them there because there's side effects to everything. When I see a cancer patient at that point, and they're usually end of life, I'll give them what they need to feel better.
Sure.
I'm going to give them the narcotic if they need it, if someone's not giving it, because we do not have anything else that helps them. And it's after seeing enough of these people, I realize that you've got to do whatever you can to make them better.
Give them the best quality of life that they have left.
Exactly.
I don't think anybody would argue with that.
Yep.
And as I say almost on every podcast here with every expert I deal with, this is why you want somebody with experience, somebody that's done this, somebody who's been around the block, because there's no substitute for experience.
Mm-hmm. The other part of it is I've been on the receiving end. I had cancer myself.
Do you mind sharing about that?
I can share that with you. It was prostate cancer, and it was a service-connected condition when I was in the military, exposure. And I can tell you from the perspective of a hospital experience. Now, I had great care. Cancer was taken care of. There was some significant pain afterwards. I had developed a complication 2 years later, which was extremely rare. Of course, it happens to healthcare workers, right? All these things. In fact, it was
lawyers, doctors, nurses. We call it the nurse curse, in fact.
Let me tell you a story about that.
Please.
I woke up, this is 2 years after my uneventful prostate cancer. I call it relatively uneventful. With terrible fever, shakes, and my wife's a doctor, and she goes, "You look terrible." And 2 days before, I was feeling fine. Did workout. I was good. I went to work.
Something's wrong.
I wake up and I'm like, this is weird. And so it turns out I had a what's called a lymphocele that it got infected. So it's think of an abscess. It's a deep abscess.
Yes.
Went to the emergency room. But they get the MRI and they go, "You've got an abscess." How in the world did that happen?
Pocket 2 years later.
Yes, 2 years later. So while I'm in, and no one's configuring it out, so they do the MRI, put me up on the floor, they give me IV antibiotics. Now I'm going to see the general surgeon. And so no one can, what is this? So I'm actually on my phone looking it up. I said, I type in, these are the symptoms. I'm starting to do literature searches, and I go, holy cow, this is what I have. So I showed it to the general surgeon. He goes, so he does his own reading, goes back, he said, I'm not going to go in there.
George, I think you're right.
If I go in there, it's going to stir things up. So,
because the lymphatics only have so many channels to flow.
If you try to,
and you block the other ones,
you try to get the infection out or wash it out, it's going to create more problem. So I had a great team of interventional radiologists that did it.
They put a pigtail in there, a little drain.
And so the drain, it didn't stop it. It went on for about a month. And I remember this. This is kind of interesting because then I went back to see my original surgeon at the hospital in St. Louis who did my surgery. And I called him. I said, "What do I do?" And he goes, "Just come over here." Because now, I've seen this before. And I get there, and it's during COVID. So now I get a personal experience into what the patients are feeling. I roll into the emergency room. I think it was 8 p.m., so it's not late. And I'm still feverish. I've had received 5 days of antibiotics, and my wife can't come in. Right. So we're in there. They put me in the emergency room. They do all the blood tests, and I don't see a physician. And I see a nurse practitioner will come in. She's trying to explain, we're going to admit you. And I thought, okay, cool. I get this. I know something's wrong. I still got the drain in.
Okay.
They bring me up, and it's like, but they don't tell me where I'm going. So I'm asking, it's like, am I going to the ICU or where am I heading? It's like to understand what my levels, what they thought, because prior to that, they had come in and said, by the way, we think you're having a heart attack. There's a chemical in your blood that goes up when your heart is
that
damaged.
Troponin?
Troponin. Well, you get it with infections too.
Yes.
So they come in to get EKG, the whole thing. So I end up in the room, and I get a very competent nurse, RN. She comes in and she's looking at this thing. She goes, and I said, am I going to, and I get a bunch of internists coming in and I know what they're doing, right? So I understand the antibiotic treatment. It's like, this drain's not working anymore. I'm not draining anything. I'm concerned that it's plugged up or something because I'm thinking they're going to have to replace it.
Right.
Well, she can't figure out the problem. So the people are coming in. So she actually calls her fiance, who's a surgical resident at a training program just down the street, right? I could hear them on the phone. He goes, well, do this with the drain. And she's doing this while he's on the phone. And she fixed it.
And then all of a sudden it starts draining again.
It starts draining again. So here's a funny thing I did, though. When I was there, I did not divulge to the physicians that I was a physician.
Oh, you didn't?
I didn't, because I wanted them to treat me without being nervous, without treating me like everybody else. And it wasn't until the last day that I said something. And because they would come in, I would ask the questions, tell me what the next thing is going to be. So I kind of got the feeling with the patient. So anyways, long story short, I got better. As I'm leaving that hospital, remember it's COVID, right?
Yeah.
Jennifer can't come in to get me. I've got to walk out, and I left my mask upstairs. And I'm getting harassed by everybody in the hospital to get a mask. I said, I get it. I said, I'm sorry, I left it upstairs. I just got to leave here. Okay, I got to get out of here. Out. So it was just a very interesting experience, but I learned that piece of it. And I understand where patients are coming from, trying to understand our healthcare system as a patient. And then they're coming in and they have all these questions about their coverage, how their healthcare is going to be delivered. I mean, it was so eye-awakening to me that it was that's now influenced everything I'm doing now. So when I see a patient, talk to somebody who has a complaint, I was like, I totally get it. And I explain to them, this is why this happened. This is what's going on. I try to understand. I can't fix everything, but this is why it's happening the way it is. So.
That's incredible, John, that you would do that. That reminds me of a movie called Brubaker. It's the real handsome actor. What's his name? Oh, I can't believe. Who was Robert Redford? Robert Redford. At the beginning of the movie, he's the new warden of a prison. He's going to be the new warden of some prison down south, horrible problems. And he has himself brought in as a prisoner, undercover, incognito. And he gets processed. He goes through the whole thing, and then he ends up being put in a cell. Yeah. And then there's this moment where he says, I'm the warden. And he's somebody, and he walks out, and becomes the warden. But he goes in incognito to see what it's really like in the prison.
Yeah.
And what he does, he says, give me a bunch of sunglasses. What? Because the prisoners had been in the dark so long, he wanted them to get outside. So they give them sunglasses, and they come out into the light.
Very interesting.
It was one of his first things he did that he learned because he went in incognito like you did.
Yeah.
Well, John, that really speaks to your fortitude and your integrity as a human being. I'm very impressed.
Oh, thank you.
Wow, what an insightful discussion we've had. Now, I'm sure we could talk forever about all the amazing things you can do for pain. But is it fair for me to wrap this up and say, with your traditional training, excellent training, years and years of experience, coupled with your knowledge of integrative and other treatment therapies and modalities, that you are getting better at managing pain? And if somebody were to come to you for a second opinion, for example, you might be able to offer additional things that they may not find elsewhere. Is that a fair statement?
That is very fair. Yes. Well put.
Yeah, because we don't want to say, hey, come to me, I'll fix everything.
No, you're right.
And in our field, especially as you're a specialist, there's churn. You go for second opinion, third opinion, and people shift around looking for what they want, and that's understandable. That's understandable. And it's important not to overpromise what we can do. But I'm very impressed with your training and your results, and clearly you're evidence-based. Clearly, you have proper criteria, and you're looking for success percentages and all that stuff. Clearly, you keep up with the current literature, and clearly you're on the cutting edge of understanding of these new medications and whatnot that are clearly offering benefits and a way forward.
Well, thank you.
Well, John, thank you very much for your time. It's a real pleasure talking to you today. And it's a real gift having you and your lovely doctor wife as colleagues here in this community.
Well, thank you very much.
Thank you again.